Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're at another redo. That's the way it goes, right? We are in the month of August. All the love that's going around. I wish the best for every single one of you. Love to all that are celebrating their solar return. So, we pick up at page 74. Welcome, YouTube. Peace. I'm your moderator and narrator, Uriel Riley, Master Fitness Trainer. So, thank you so much for being here and reading with us. We begin on page 74 at the middle. Mechanical support of ventilation. Static lung mechanics refers to the properties of the pulmonary system that relate to the interaction of forces without motion. An understanding of these static properties is essential before the principles of dynamic lung mechanics can be appreciated. Dynamic lung mechanics refers to the properties of the pulmonary system as they relate to the interaction of forces taking motion, kinetics, into account. Both of these properties must be dealt with in artificial ventilation. Static lung mechanics. We stated earlier that the lung is an elastic organ and will manifest changes in pressure with changes in volume. Simply stated, within the elastic limits of the lung, the pressures measured will be proportional to the volume which is in the lung. P is proportional to V. We have defined elastance as the forces tending to collapse the lung. Elastance may also be thought of as the summation of forces resisting distension of the lung. It must follow, then, that the pressure necessary to inflate the lung must be equal to the product of the elastance times the volume. P equals E times V. This intuitive relationship is obvious if one considers the pressures exerted within the lung as dependent upon the volume in the lung and the elastic forces resisting the pressure of that volume. By definition, compliance is the reciprocal of elastance. C equals 1 over E. Compliance, therefore, is equal to the ease of distensibility of the lung. In other words, the more easily distensible the lung, the greater the compliance. The lesser the ease of distensibility of the lung, the lower the compliance. Compliance can now be referred to in terms of the volume-pressure relationship by the following derivation. 1. P equals E times V. 2. C equals 1 over E. This may be rearranged to read 3. E equals 1 over C, replacing E in equation 1 with equation 3. 4. P equals 1 over C times V. Rearranging this equation to solve for C. 5. C equals delta V liters over delta P centimeters H2O, which is the change in volume over the change in pressure. Thank you so much for being here and reading with us. Hi, it's Heart Love. We are reading an MCAT preparation book, Clinical Application of Respiratory Care. Thank you so much for being here. Hi, it's Heart Love. Thank you, Dante. Peace, peace. Yes, that's what we do on this channel, read books and learn from masters. And I'm a master fitness trainer, so giving people the gems for free. This is for information to help us have self-wisdom and knowledge of self. Master thyself. The volume pressure relationship stated in equation 5 is graphically depicted in figure 310. Volume is represented as the lung volumes, and pressure is represented as above or below atmospheric pressure. One can see that the volume pressure relationship is indeed a linear one until either 1. The total lung capacity is approached, or 2. Residual volume is approached. In other words, in the normal lung, any static relationship of pressure and volume will be linear as long as the volumes are not at the extremes of approaching total lung capacity or residual volume. And so, here we go. Figure 310, what you have is the volume on the side, which is you have total lung capacity at the top. So, and you have residual volume down at the bottom, and you have functional residue capacity in the middle. And as you see, from the negative to the positive. So here we go. Thank you so much for reading books with us. This corner of YouTube where we read books and learn from masters. This is Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition, 1979. And I'll read it for you. It says 310. The theoretic lung compliance curve, see text. TLC is total lung capacity. FRC is functional residual capacity. And RV is residual volume. The 0 represents atmospheric pressure. Transpulmonary pressure is the difference between mouth pressure and pleural pressure. As transpulmonary pressure increases, the volume within the lung increases. Volume pressure relationships within the lung are linear as long as TLC or RV is not approached. Points A, B, and C depict that in appropriate lung volume ranges, a change in pressure results in a linear change in volume, and vice versa. This represents theoretic static lung phenomena only. That's the key right there. Peace, highs, heart, love. Thank you so much. Thank you. Yes, we read books and learn from masters on this. This is preparing everyone in the next generation for their MCAT. Yes, super high level book. It's a $3,500 book. And we're reading it here live from the light in LA to the people for free on this channel. That's what we do. We're the light workers. Thank you so much for your time and care. So that's the figure. Here we go. Page 76 at the top. The volume pressure relationship is true for the lung. However, we have previously stated that in artificial ventilation, one must not deal out only with the lung, but with the chest wall as well. The term total compliance refers to the system compliance, i.e., lung compliance, plus chest wall compliance. Specific compliance refers to a patient's lung compliance in relationship to the patient's actual lung volume. Specific compliance allows for more accurate measurements of compliance when the patient's size varies significantly from the normal adult, and especially important factor in pediatrics. Effective static compliance, ESC, is a method that has been described for approximating the total compliance of a patient on the ventilator. See Chapter 23. This is obviously not a true measurement of compliance since the definition requires static conditions, which are cumbersome to produce in the clinical setting. However, many clinicians feel that the ESC is a useful serial measurement of volume pressure relationships within a particular patient, and it is used to reflect gross changes in lung compliance when chest wall compliance is controlled and remains relatively constant. This usually applies to the patient who is paralyzed or heavily sedated, so that voluntary muscle activity is non existent. Of course, the airway, the ventilatory circuit, and the manner of delivering the volume must remain constant. Then, a series of effective static compliance measurements made over a given time period can determine gross changes. When present, in lung compliance, effective static compliance is calculated by dividing the expired tidal volume, ml, milliliters, by the inspiratory pressure, centimeters H2O. Dynamic lung mechanics. Thank you so much for the likes and subs. We are pushing towards 500 on this channel where we read books. Thank you so much. Oh man, self-knowledge is key, right? That's why we're here. Master thyself. I love it. I love it. I love it. Down the bottom of page 76. Thank you. You can go back through all the replays and the list on this channel, and you can just sit and click on the playlist and read the entire book. Yes, we're using this platform for that. Thank you so much for the love. Man, much love. This is a key section right here, okay? Dynamic lung mechanics. Whereas static lung mechanics deals with the property of compliance, dynamic lung mechanics deals with the property of resistance. The force driving pressure of a gas will determine the flow through the system. Obviously, the other major factor that will affect the flow will be the forces impeding the movement of gas. This can be stated by the relationship that the driving pressure, the delta P, will equal flow times resistance. Delta P equals F times R. Stated in terms of resistance, resistance R will be equal to the driving pressure divided by the flow. The R equals delta P over F. Resistance is determined by numerous factors, including viscosity, length of tube, and the radius. Poiseuille's law. Recall that in the tracheobronchial tree, both laminar and turbulent flow coexist. 95% of the total resistance is due to airway resistance. It should be remembered that the resistance of the airways does not remain constant but changes, increasing as airways get smaller, exhalation, exhalation, and decreasing as airways get larger, inspiration. Driving pressure refers to the difference in pressure between the mouth and some other reference point. There are three common points of reference. 1. The alveolus. 2. pleural space. And 3. Pressure immediately surrounding the exterior chest wall. These pressure differences can be quantitatively defined in conditions giving static measurements, compliance, and dynamic measurements, resistance. Trans-airway pressure is defined as the driving pressure between the mouth and the alveoli. See Figure 21.1. It represents the pressure drop along the entire airway and is reflected in the measurement of airway resistance. It is meaningless to refer to trans-airway pressure measurements in static lung mechanics since the pressures between the mouth and the alveoli are in equilibrium. Therefore, trans-airway pressures can only be meaningful when measurements of airway resistance or dynamic lung mechanics are ascertained. Transpulmonary pressure has been defined as the pressure difference between and the intrapleural space. Intrapleural pressures are usually approximated by the pressure measurement in a balloon in the mid esophagus. Transpulmonary pressure represents the drop in pressure from the mouth across the lung parenchyma. Its measurement is used in the calculation of pulmonary compliance under static conditions and pulmonary resistance under dynamic conditions. Transthoracic pressure is defined as the pressure difference between the mouth and the area immediately surrounding the chest wall. This measurement must obviously be made in a rigidly controlled environment, such as a patient in a body plethysmograph. Transthoracic pressure is a reflection of the measurement of the total compliance and or the total resistance, lung tissue, and chest wall. Lung impedance. Welcome. Thank you so much, Highest Heart Love. Thank you for the likes and subs. We're pushing towards 500 reading books. Thank you so much, Dante. Thank you, Georgina and Pit Lane. Highest Heart Love. Thank you all for being here and reading books. This is what we do in this corner of YouTube, the peaceful part of YouTube where we read books and learn, right? This is what I do. This is what I'm supposed to do. I went to the top of the mountain and literally was talking to the burning bush, and it said this is what I was to do, to come and give all information that I received while I have time left here. Thank you so much. We do that archangel work here. All right. Thank you for reading with us as well. Love to all the book lovers community. Lung impedance. In providing inspiration, a mechanical ventilator or the muscles of ventilation must expend enough energy to overcome lung impedance. 1. The elastic recoil properties of the lung and chest wall. And 2. Airway resistance. In other words, both static and dynamic forces must be overcome in order to deliver any given volume to the lung. Mathematically, the total differential pressure, delta P total, is a reflection of the compliance and resistance characteristics of the lung thorax system. The equivalent values of delta P compliance and delta P resistance can be placed in the equation to illustrate more clearly their contribution to the total pressure difference. And here we go. We're at the top of page 78. So you have pressure total and compliance and resistance. Thank you so much for reading with us. Clinical application of respiratory care. Preparing the next generation for their MCAT by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. second edition. So there we go. In a patient with very stiff lungs, i.e., a low compliance, it may be seen that a greater component of delta P compliance and total pressure will result for any volume added. Also, if resistance is increased, it will also add a greater component to the total pressure. Once flow approaches or equals zero, the total pressure will be solely a reflection of the compliance characteristics of the system. It should be re-emphasized that this phenomena exists whether the patient is on the ventilator or breathing spontaneously. All right, in the middle of page 78, we're moving on, we're flying through it. Chapter 3, the mechanics of ventilation. Thank you so much for reading books with us. Negative pressure ventilators. To create the movement of air into the lungs, it should be obvious that the basic essential is to develop a driving pressure between atmosphere and the alveoli. In normal, spontaneous ventilation, this driving pressure is produced through the work of the ventilatory muscles. When artificially supporting the ventilatory system, the driving pressure is provided by an external mechanical apparatus. A negative pressure ventilator is one in which the body is placed within a chamber that can produce a subatmospheric pressure. The head remains outside of the chamber, and therefore, when a subatmospheric pressure is produced around the chest wall, a driving pressure between ambient atmosphere and the alveoli is produced. The iron lung is a classic example of a negative pressure ventilator. A newer type of negative pressure ventilator is the chest cuirass. It is far more portable than the iron lung. The prime advantage of a negative pressure ventilator is that long-term ventilatory support is possible without an artificial airway or endotracheal tube or tracheostomy, tracheo, tracheostomy. This permits the patient to talk and eat, and it avoids the numerous discomforts and complications of artificial airways. This mode of ventilatory support proved extremely valuable in the days of polymyelitis epidemics and is still frequently used for the long-term ventilatory support of neuromuscular diseases. The main disadvantage of a negative pressure ventilator is that the patient's body is not readily accessible for the nursing and monitoring needs of critical care medicine. Observation becomes nearly impossible, and availability of the trunk and extremities for measurements and administration of medication is most difficult. Another great disadvantage is that diseased lungs rarely manifest uniform changes in resistance and compliance. As early as 1947, it became apparent that pulmonary gas exchange was maintained in acutely ill patients far better with positive pressure machines than with negative pressure machines. In essence, then, negative pressure ventilators can still be used for the long-term support of the chronic ventilator patient who has reasonably normal lungs. However, for the support of ventilation in acutely ill patients and in those with primary cardiopulmonary disease, negative pressure ventilators are not satisfactory. Key. And see, we also know now we are in the era where we have CPAP machines. I use CPAP machines on my clients while they're breathing and I'm stretching them or doing the pressure points. Oh my goodness, you talking about masterful benefits. Whew. I mean, all types of cancers just gone. And they would leave. The first place where I would see the cancer cells dissipating when they were going to the oncologist and get them checked would be in the spine, in the back, in the lower spine. Yep, yep. We can do it. We can heal one another. This is how we do it. Giving ourselves care, respiratory care. Thank you so much. Highest heart, love, and honor. That's what light workers we do, you know? That's exactly what we do. Thank you so much. Positive pressure ventilators. How, y'all? Oh, how's it feel? Thank you. Oh, peace, Turga. Oh, Seni Senora. Oh, Yvette. We are reading Le Livre. Clinical application of respiratory care. Thank you so much. Thank you. Positive pressure ventilators in the middle of page 79. An inspiratory driving pressure may be provided by applying an above atmospheric pressure to the mouth. Since the alveoli are at atmospheric pressure, this will allow inspiration to take place. By removing the positive pressure from the upper airway, expiration takes place in a manner similar to that of a patient breathing spontaneously. The lung and the chest wall provide elastic recoil, creating a driving pressure from the alveolus to the mouth. This method of intermittent positive pressure ventilation, IPPV, is the method presently used for the mechanical support of the ventilatory system in the acutely ill patient and for augmentation of bronchial hygiene. Advantages. This technique of providing a driving pressure allows direct control of the driving pressure and, therefore, a greater chance of providing the desired ventilation. In addition, attachment to the apparatus is accomplished through a small tube leading to the airway. The bulk of the apparatus is located a reasonable distance from the patient. This allows complete patient accessibility in the acute care settings. Disadvantages. An artificial airway, endotracheal tube, or tracheostomy tube must be provided except when support of ventilation is for a very short term. This means that positive pressure ventilation must carry with it the complications and risk of artificial airways. Pressure dynamics of the thoracic cavity are dramatically altered by positive pressure ventilation. Normal intrathoracic pressure in the spontaneously breathing patient is never above atmospheric. Mean subatmospheric intrathoracic pressures play an important role in cardiac functions. Under normal circumstances, intra-abdominal pressures are higher than intrathoracic pressures, and therefore, blood within the great veins is milked from the pelvis and abdominal region to the thorax. This mechanism is called the intrathoracic pump and plays very important role in ensuring adequate return of venous blood to the heart. When intrathoracic pressures are increased to above atmospheric there is a potential embarrassment of blood return to the heart. And that's where we'll pause this reading. See, I got the bougainvilleas on my fingers playing in the flowers. It's been a beautiful day in the evening. We will pause right here, page 80. When we reconvene, we'll be going into the last part of this chapter 3, the mechanics of ventilation, classification of positive pressure ventilators. Man, it's hard. So honorable. Thank you so much for being honorable in the chat. What a love life. This is so awesome. Yes. Much love to all of you, all the book readers, all the authors, the poets, the griots. Highest heart love to all of you. When we reconvene with clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. MCAT material, master reading, coming to you live from the light here in LA. Thank you so much. I love you. You mean so much to me. Much honor and love. Thank you, thank you, thank you. We shake it up in the world, reading books on YouTube. They try and make it difficult, and we just keep showing up, right? Thank you so much. That's how I am built. I can't half step. I have to do it correct. And so when you see me post something and do something and then take it off and go back and do it again, just know that this time is going to be better. That's part of how life is. That's what mastering is doing. Getting better every day. Shake it up in the world. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Thank you so much. A drink of love water to you and my love. Thank you so much to my mods. Peace, highest heart love. Thank you so much. Thank you, Mystic Breeze. Gratitude, highest heart love. Thank you, Marquise, Coco, pushing plant based. All my friends and family. I love you. My daughter, love you so much. Eagle, sunflower, wolf. Happy summer. I'll see you soon. I love you. I love you. I love you. I love you. Thank you so much for being here, reading with us. Highest heart, love, and honor. Let's breathe. Here we go, and then I'll take you out. I love you. I love you. You. I love me. I love you. Y'all have a wonderful evening. I will see you soon. Peace, peace.